Assalamu alaikum wa rahmatullah. So after we finished the disorders of the shoulders and the elbow and wrist, now we're moving to the hand. We will talk about the acute infections, rheumatoid arthritis, osteoarthritis, acquired deformities, vascular disorders, and some of the congenital variations. It's a very wide subject. I'm going to make it as short as possible. So for the acute infections, like in orthopedics, usually when there is an infection, the most common cause of the infection is the staphylococcus. Staphylococcus is the most common so far. So the pathophysiology, along with any infection, there will be inflammation, the inflammatory process, and there will be redness, swelling, hotness, and you all know these signs and symptoms. There will be tissue necrosis, and there will be increase in pressure, and there will be throbbing pain because of the congestion. So in history, usually in history, it may be preceded by trauma. So whenever you have an infection in orthopedics, there's a lot of causes. Either it's idiopathic or primary, or there is a cause, which is trauma, puncture, stinging, abrasion, laceration, penetrating trauma, and so on. Sometimes it will take some time to have infection. Usually, as you all know, when you have a cut wound or something, infections usually need like 4 or 5 days until you can see signs and symptoms of infection. You should know that your patient is having diabetes or not, if he's taking any intravenous drug abuse, immunosuppression, because all of these diseases may increase the risk of the infection. And on the other hand, the patient may not present as a normal patient who will be having an infection because of the immunosuppression. So the reaction for these patients won't be the same. So you have to be careful for these patients. For the examination, you have inspection, palpation, percussion, auscultation in the normal exam. In the orthopedics, we have look, feel, and move. So by inspection, by looking, you can see the redness, the swelling, the asymmetry, deformities. Then you go feel, you can feel the tenderness, the temperature, the pulses, the neurovascular. Then you will go to move. Okay, now for the diagnosis. For the diagnosis, for sure, you have to know the history, what's happening, if there is an insect bite or a tendon rupture or whatever you have, like acute gout disease or something. You have to get the X-ray, because in the X-ray, you may see like a foreign body. For example, if one had a shotgun or a gunshot or so whatever, you can see the bullet or you can see the foreign bodies inside the limb, which may precede for infection. So the problem is after a few weeks, it might go into the bone and it might cause osteomyelitis, or if it's in the intra-articular space, it will be septic arthritis. So you have to have this information prior to treat this patient. What's the treatment? Like any other infections, you have to know, for example, or for sure, you have to know what is the organism inside. So usually before giving any antibiotic, you have to get cultures. You have to get cultures. So antibiotics for sure, rest and splintage. Sometimes if there is pus, you have to do drainage and then rehabilitation. The type of antibiotics is mandatory, is very important. Usually if it's gram-stain, staph, you should give anti-staph. I see like a lot in the hospitals, like new doctors, they give, for example, amoxicillin for the cut wounds as prevention, which is amoxicillin is not an anti-staph. So you have to be careful. You can give instead first generation cephalosporin, like the cephalexin, which will work against the staph. So fluoxacillin, cloxacillin, oxacillin, or cephalosporins if you have an infection. Fusidic acid may be added for sure. If you have a bite, you might add penicillin. Okay, it's very important sometimes to add penicillin. The worst bite is the human bite, as you all know. Metronidazole, for sure, if you have agriculture injuries, because there will be anaerobic organism, and you may change the antibiotic later when you have the cultures. So you get cultures, you start a broad spectrum antibiotic based on the history and physical examination, and after 2, 3, 4, 5 days, whenever you have the culture, you change the antibiotic to the sensitivity. Rest, splint, and elevation, because you will decrease the inflammatory process, so less pain in the functional position. In the functional position. Drainage, if there is pus, if there is foreign bodies, if there is waste inside, you have to go and do irrigation, or if there is pus, you have to drain and incision and drainage. It's very important when you do the incision, it's like the picture. As you can see, these skin creases that you all have in your hands, you should not cross them with your incision. There is no vertical incision for the hand, okay? Because you will cause contractures and it will affect the function of the patient. Post-operative, for sure, rehabilitation. Now in the hand infections, we have like, these are the commonest you may see in a patient: the paronychia, the PULP infection, the herpetic, whitlow, subcutaneous tissue, tendon sheath, and deep fascia and the joints. For the paronychia, it's the commonest. It's very common, especially in the pediatric age group, in the kids, because they always, like, they are biting their nails. So there will be tenderness around the nail. It's called paronychia usually. It's self-limiting. If there is pus inside, you have to do incision and drainage, and you may give antibiotics, and you have to make sure that it's not fungal infection. Now for the FELON, for the PULP infection, it's distal pad. The problem is it's a closed fascial compartment, which is increased pressure, increased pain. It's very painful, throbbing pain. That's why you have to sometimes do incision for it to reduce the pain, painkillers, and antibiotics. Now for the herpetic whitlow, okay, it's like the herpes simplex, you know, there's vesicles. This is the most important sign you might see in these patients, that you have vesicles. It's usually self-limiting. It's a viral infection. Within 10 days, everything is going to be okay. The subcutaneous infections, this is more serious now. We're getting more serious because there will be hand blisters. The problem you will have, the signs of infection, like overwhelmed. You will see a big, like, swelling, tenderness, redness. The hand, the human bite is one of the worst bites you might get. So if you have an MCQ, what's the worst bite? The human, the cat, the dog, so whatever, the human bite is the worst because of the microorganisms in the mouth. Tendon sheath, very important. It's not very common, but it's very important. Suppurative tenosynovitis, tendon synovitis, because there is around the tendon a sheath and a synovium. So whenever the tendon is moving, there will be more inflammation, more pain, and there is infection, pyogenic tenosynovitis, which is infection by an organism. So the tendon sheath, the problem is a closed compartment. That's why it will be more painful and a good place for the bacteria to grow. For sure, these bursa also communicate with Parona's space in the lower forearm. So you might see a patient who's having a suppurative tenosynovitis and it's extending to the forearm. So it's not uncommon. Pyogenic tenosynovitis is uncommon, but it's dangerous. It usually follows a penetrating injury. So if you have a penetrating injury, be careful of these patients, keep close observation to them. The affected digit, for sure, it's going to be painful, swollen, slight flexion, because it's going to decrease the pain. Because if you do extension, it will increase the pain. You remember compartment syndrome? When you have, for example, volar compartment or in the flexor area, when you do extension or passive stretching of the compartment, it will induce the pain. That's why inducing the pain in these patients will be by do extension. For example, in first picture, you can see flexor tenosynovitis in the middle finger following cortisone injection. So it might be a cause from a cortisone injection. That's why you have to tell your patient before giving him a cortisone injection that it might get infected. This is one of the complications of the injections. Tuberculous synovitis of the flexor pollicis longus. And as you can see, he's trying to extend the thumb, but it's not extending. That's why it will be more painful. Diffuse septic extensor tendinitis, okay, which is, you can see it on the dorsal aspect of the hand. KANAVEL'S sign. KANAVEL'S sign, it's very important. What's KANAVEL'S sign? There are four components. The first one is flexed posture of the digit. So for example, if it's for the index, it will be flexed digit. This is the first component. The second one, tenderness along the course of the tendon. This is number 2. 3, pain on passive extension. Pain or passive extension or active flexion. So it's pain. And the last one is fusiform swelling of the whole finger. So when you look at the finger, you can see that it's swollen. It's like a sausage. So these four components, it give you KANAVEL'S sign. So KANAVEL'S sign is very important to diagnose, and it will give you a high index of suspicion that this patient might having tenosynovitis. The fascia space compartment, the large, thinner, and the mid palmar space. So you can talk about the palmar space and the mid thinner palmar fascia. These two places usually after penetrating injuries or secondary spread, they might get infection. Closed compartments again, infection. For the septic arthritis, it's like any synovial joint. It's like any synovial joint, same organisms, same pathophysiology, everything is the same. Redness, hotness, swelling, so whatever. Rheumatoid arthritis, we already talked about many diseases or many places that's affected by the rheumatoid arthritis. In the hand, it's just the same. It's just the same. The only difference that it has specific shape for the hands, which is this picture showing the rheumatoid hands, okay? Sometimes when the disease is more severe, you might have dislocations in the rheumatoid deformities. So you can see here the rheumatoid deformities, okay? Ulnar deviation of the metacarpophalangeal joints, okay? Okay, for these patients, usually they have weakness, generalized weakness, and it's multifactorial, okay? Usually these patients, because of the muscle wasting, the pain, disuse, so they are not moving their limbs. That's why there's gonna be like a vicious cycle. Not using their limbs, more weakness, more pain, not moving, and so on. So it's gonna be more and more. So they might have also rheumatoid nodules, which is very common. Okay, it's common in rheumatoid patients. And this is X-ray. You can see this is the start, and it's more and more severe. And this here you are seeing like dislocations even in the MCP joint. Treatment, as I said before, for the whole rheumatological diseases, treatment. Painkillers, rest, might be cortisone, and the last step will be surgical synovectomies, okay? And as you can see here, these are the extensor tendons, okay? The extensor digitorum tendons. And after that, they went in and they did synovectomies. So that the synovectomy, you are removing the source of this problem. So people might get better. Sometimes if the joints are dislocated, unstable, we can go in and do replacements, as you can see in these stages in the pictures. Osteoarthritis. Postmenopausal women, usually after 65 years, they will have osteoarthritis. So osteoarthritis, pain, swelling, tenderness, decreased joint space, osteophytes. As you all know, in the osteoarthritis lecture, we already talked about in the past. Sometimes we will have like nodules, like Herpetic nodules, as you can see in here, Herpetic nodules and Butcher's nodules, okay? One in the DIP and one in the PIP. Swelling of the fingers, for sure. We have some acquired deformities, and the difference between those and the acquired, that the acquired are caused by trauma, usually. Trauma, infections, concomitant diseases, and so on. So we have skin contractures, DUPUYTREN'S contractures, tendon lesions, bone, and neuromuscular disorders. For the skin contractures, usually it's palmar skin. And as I told you before, never ever go and do vertical incisions over the skin crease, because it's gonna cause contractures, and it will affect the function. And we have a very important disease to know about, which is DUPUYTREN'S contracture. DUPUYTREN'S contracture. So DUPUYTREN'S, we have the palmar fascia in the hand, as you can see in this picture. So this palmar fascia, what's happening, that increased collagen synthesis, okay? It's an autosomal dominant trait, okay? It will cause hypertrophy, more contracture, more hypertrophy. So there will be flexion, okay, which is permanent flexion of the digits. The most common digits is the 4th and the 5th. So these are the most common. So the patient will be presenting with a deformity. So what to do for this patient? There is a lot of studies that physical therapy, some people try to give some local injections like collagenases and so on, but the problem is that the recurrence rate is very high. That's why surgical sometimes, for people who are smoking and on alcohol, they are in risk factor, and it's more incidents to happen in patients with diabetes, 8 and so on. What to do for these patients? You have to do history, physical examination, and so on. And if you can see puckered, nodular, thick fascia in the palmar aspect of the hand. What to do for these patients? These are like some pictures. So what to do for these patients? Usually you do operation, and you go and do Z-plasty like you can see in this surgery, and healing is complete after 2 weeks. Good. What about the tendon lesions? Very common. We ask a lot about them in the exams, especially in the OSCEs. Mallet finger, boutonniere, swan neck, and rupture APL, dropped finger, and trigger finger. So what's a mallet finger? Mallet finger is extensor tendon at the terminal phalanx. Usually it's when the patient is falling down and they're trying to hold their hands, the extensor tendon pulls a muscle, okay, pulls the bone, and it's happening. It might be an avulsion fracture, or it will be a cut in the tendon. So usually it could be also from direct trauma. So what to do? Splint, mallet splint for 8 weeks, then 4 weeks for night splintage. So don't forget 8 weeks. Yeah, it's a long treatment because it's a tendon problem. And this is a picture of a mallet finger. Now the boutonniere, the problem is flexion deformity of the PIP. So the proximal is flexed and the distal DIP is extended. So this is boutonniere. There is a problem where? There is a problem in the central slip of the extensor compartment. So there is a problem in the central slip in the extensor compartment, usually caused by direct trauma or rheumatoid disease. As you can see here, central slip, there is a problem in it. So there will be hyperflexion of the PIP and extension of the DIP. This is called boutonniere. What to do? Splintage for 6 weeks. And if there is long-standing deformities, it might be corrected. Or it might be left alone for sure. It depends on the function and the presentation of the patient. Swan neck deformity, it's the other way around of the boutonnieres, okay? So the PIP, it's hyperextended. The PIP in boutonnieres was flexed. Here it's hyperextended and the DIP is flexed. So this is called swan deformity or swan neck deformity. Okay, what to do for this patient? You might give them a figure of 8. Figure of 8, it's to cause some flexion. You are trying to conceive these patients. Ruptured extensor pollicis longus, because it's doing extension of the thumb, you will lose the extension of the thumb. It could be alone, injury alone, for example, by a cut or cut wound or something, or it might be from a fracture, as you remember, upper limb fractures, Colles fracture, or it might be with rheumatoid arthritis. So what to do for these patients? Direct repair is unsatisfactory, and the tendon transfer using extensor indices is needed, especially for these patients who have chronic diseases. Dropped finger, usually sudden loss of function of extension of the metacarpophalangeal joint. So usually it's for tendon rupture. Tendon rupture at the wrist. So what to do? The direct repair is not possible. The distal portion of the tendon can be attached to an adjacent finger extensor. Okay, trigger finger. Very important, very important, very common, very common. So what's a trigger finger? As you all know, for example, in the flexor aspect, for the flexors, for the flexor tendon, we have something called pulleys. What are the pulleys? We have the pulleys, it's like a holders inside that are holding the tendons, not to do bow stringing. So if you don't have these clips here, the tendon will be like this, like looking a bow. So that's why there are some clips which are the pulleys. You have many types of pulleys, the C, the A. Usually, the most common pulley that is causing trigger, it's the A1 pulley, the A1 pulley. So what's happening? Either the tendon is inflamed, it's getting bigger, the pulley can't handle the tendon. So what's happening when you flex the tendon, this is the pulley, it's like this, and the tendon is going inside. So what's happening if the tendon having an inflammation or it's getting bigger, it's trying to go inside, so now it's not going inside. So what's happening? That the patient's starting to feel pain. This is the first step, and tenderness over it for sure. Then the patient will flex and extend with a tick or a trigger. It's just like the trigger of a gun. So then the patient will flex his finger and he cannot return it back to normal. So he will return it with his hand. The last stage, the finger will be flexed and he can't, even with his hand, to get it back to its normal position. So what we do, the treatment depends on the patient. So in the first stages, usually we can give painkillers, physiotherapy. In the second stage, if it didn't work, failure of conservative management, we can go and give an injection of corticosteroids around the A1 poly, which will reduce the inflammation that's happening and makes the tendon bigger. It might work. The problem is at later stages 3 and 4, we have to go and do surgery. What's the surgery? It's very simple surgery. We go in and we cut the poly. So we cut one of the pulleys. And no, you won't have bowstringing from only one poly. So on the left side, as you can see here, we can give corticosteroid injection. On the right side, they opened and they released the poly. So this is the trigger finger, like very fast. Infantile trigger finger is the same. We usually do the surgery at 1 year, at 1 year old. Bone lesions, after like acute infections, tuberculosis, malunited, infantile rickets, and so on. Usually we have to treat the underlying cause, and after that you may need some corrections, osteotomies or internal fixation. Neuromuscular diseases is very wide. We have a lot of diseases. It's complicated. It's a gray zone between pediatric orthopedics and pediatrics. So we have shortening of the intrinsic muscles, ischemic contractures of the forearm, peripheral nerve regions. So shortening of the extrinsic muscles, the characteristic deformity, flexion of the MCP, extension of the interphalangeal joint, and a deduction of the thumb, okay, which is called intrinsic plus hand. Intrinsic plus hand, which is spasticity, like in cerebral palsy, volar subluxation of the MCP joints, like in rheumatoid disease, as I showed you in the last pictures, scarring after trauma or injections, and shrinkage due to ischemia. What's the treatment? Triangular resection of the segment of the intrinsic aponeurosis, which is called Letter's operation. Volkmann's contracture, do you remember the compartment syndrome? When we talked about that compartment will stop the blood supply and there is no blood is going to the limb again, so there will be persistent flexion. And it's gonna be like this, which is the Volkmann's contracture. Peripheral nerve lesions, we will talk about it in special lectures like nerve injuries, about the radial, the ulnar, and the median nerve, so we won't talk about this too much. We have for sure vascular disorders, we have the emboli, and you can see here, this is a huge emboli that's closing the whole hand. Sometimes when you see this image, unfortunately, if it's dry, you might wait for it to slough away, or you can do amputation, depends on the vascular surgeon consultation and the orthopedics. Raynaud disease and Raynaud phenomena is, you can see that there's difference in the color of these fingers depending on exposure to cold, O2 supply decrease, cyanosis, warm environment, hyperemia. So Raynaud phenomenon comes with many diseases. Okay, ulnar artery thrombosis, we already talked about thrombosis. It's very important to keep in mind. These patients you have to consult for a vascular surgeon. Congenital anomalies, we talked about a few of them in the pediatrics, okay? Like transverse failure in the first one, radial club hand, we talked about it last lecture. This is concentric rings. So the constriction rings, these, they might have it in the fingers or in the toes. It's very important to diagnose these patients as early as possible and to know the stage of this disease so we can manage them as early as possible. Campodactyl, okay, in this picture, and finally cranodactyl. So a lot of deformities, it's not so easy. It's good to know the names and the deformities, just like this. Thank you very much, and we'll see you in the next lecture, hopefully.